can start it.
Good evening, everybody. On behalf of the ECG study group, today we have got the speaker, a man with multi-dimensional personality, Dr. Abdullah Jamil. After Jamil's talk, if time is available, there will be a case presentation by Dr. Rafiq Ahmed sir. So everybody is requested to wait for the Rafiq Ahmed sir's presentation. First of all, I will request Rafiq sir to introduce Jamil, thereafter Abdullah Chaudhary, as because Abdullah Jamil is a man with multi-dimensional personality. So, sir, I'm requesting you to introduce Dr. Abdullah Jamil.
Good evening. It's my pleasure to introduce Jamil. I will not call multi-dimensional personality, then it makes us psychiatric patient, but I think he has multiple talents. I mean, no question about it. A painter, a writer, poet, singer, and a philosopher also. He's a good teacher and excellent clinician. And I think he should be an example for all of us because of his integrity in healthcare and good care of the patients. And it shows us one thing, that we can do many things. Be honest, sincere, take good care of patients, and do extracurricular activities. And overall, and also on the top of, he's a very religious person, and that shows there is no conflict between art and religion. It may be a controversial statement. I strongly believe that people should follow some religion. I do not preach for any religion, but I think being religious gives a virtue to any individual. And Jamil is one of those individuals, and it's a pleasure to know him for many, many years. Adud, please.
Assalamu alaikum and good evening, everybody. Jamil Bhai is not a doctor only. He's a singer, he's a poet. And as Rafi sir has rightly mentioned, he's a very good clinician and a very good human being in his heart. Perhaps that's the most important thing of all. Jamil Bhai, we are really blessed that you are with us. And would you please start your presentation?
Thank you very much. Thanks to Athar Bhai, Rafiq sir, and Wadud for speaking nice words about me. I don't know how much I am is like that. Today, let me share my screen. Is it visible?
Yes, Jamil,
Yes,
visible.
well visible. After you check equation, one glass equation.
So today I'm going to talk on normal ECG variants in adults. We can define this as normal variants can be described as constant ECG pattern that are neither linked to corresponding typical symptoms, not to corresponding clinical and amnestic findings, and not to drugs. The presence of such findings without coexisting cardiac pathology is particularly common among young persons and athletes. Misinterpretation of normal variants can lead to cardiac invalidism. Even today, ill-advised diagnostic and therapeutic interventions may be based on normal variants. The differential diagnosis of normal variants definitely are the pathologic conditions. So I'm going to talk over these headlines: the sinus rhythm, the sinus bradycardia, tachycardia, and sinus arrhythmia. PR or PQ interval may be short or long. QRS complex axis, QRS patterns, Q3 type, QS V1, V2 type, notching versus pseudo notching, pseudo delta wave, QRS low voltage, incomplete bundle branch block. ST segment, common pattern of ST elevation, that is ST elevation in V2 or V3. Rare pattern of ST elevation is early repolarization and some QF abnormality, UF abnormality, prolonged or shortened QT interval, arrhythmias, day-to-day, and circadian variation. Sinus rhythm, the sinus bradycardia, often seen as a normal variant in individuals at rest and usually in athletes. One example is Björn Borg, of a Swedish renowned player. His resting heart rate was 40 beats, around 40 beats. Episodes of a rate less than 40 per minute were observed in young healthy people in 24% of men and 8% of women. It may be present. Sinus pauses up to 2.06 seconds in men and 1.92 seconds in women. Sinus tachycardia, normal during exercise and under conditions of mental stress. This is one example of sinus bradycardia in a healthy person, and the heart rate is around 45 beats per minute. And this is one sinus tachycardia, heart rate is around 110 beats per minute. Now comes the sinus arrhythmia. Generally, sinus rhythm is not completely regular, especially at low rates. There are some irregularities. When deviation exceeds more than 15% of basic rate, the term sinus arrhythmia is used. In young healthy people, variability may exceed 50%. Types of sinus arrhythmia, respiratory sinus arrhythmia, normal phenomenon in infants, children, and young adults. Non-respiratory sinus arrhythmias occurs in elderly and usually associated with underlying heart disease and raised intracranial pressure. Ventriculophasic sinus arrhythmia typically seen in complete atrioventricular block. The PP interval enclosing a QRS complex is shorter than PP interval not enclosing a QRS. So this is a typical phasic change in rhythm. In respiratory phase, during inspiration, the heart rate increases, and during expiration, it decreases. And this non-respiratory sinus arrhythmia can be only distinguished during recording the ECG, whether it is associated with phasic variation of the rhythm. And when this is example of ventriculophasic sinus arrhythmia. So if we see this 2 PP interval enclosing one QRS complex is shorter, and here is one P and is another P. This interval is longer, which does not include a QRS complex. PR or PQ interval.
Hello.
It may be short. It may be short in healthy individuals. A shortened PQ without a delta wave and without paroxysmal supraventricular tachycardia is occasionally encountered, and prolonged interval in AV blocks in normal individuals like AV first degree AV block 8% in men and 12% in female. Intermittent AV block type 2 when Quebec is present in 6% of male and 4% of female, especially in athletes and during night. That's
Dr. Jamil.
axis.
Hello,
Sir.
Jamil.
Sir,
Can you back to your previous ECG, please?
this one?
This one.
Yeah.
So this is an example of ventriculophasic. Rofik, sir.
Yes.
Sir,
Yes.
why it is not the, sir, atrial ectopic, sir? As because.
Oh, no, Jamil has pointed out, I mean, you will see this when there is either complete heart blocks or some degree of AV block. So if you look at the first QRS that's conducted, and then there is a Wenkeba AV block. And in the process, there are some QRS complexes in between two, and it brings it together. So I think it's a good example of showing ventriculophasic sinus arrhythmia. So it's underlying Wenckebach heart block.
Thank you, sir.
Rafiq bhai, there is in that example, the last one, it's a little complicated than more ventricular phasic sinus arrhythmia, because some of these, if you look at some of these, like first, second, third beat of QRS,
Yes.
and then, but if we, I think sinus arrhythmia is we have to trace all the PP interval, and then, but if you look at some of the QRS complexes, these are like, I'm not sure whether these are captured beat from the preceding P wave.
Yes,
Because
two possibilities. The first P is conducted, second P is conducted, third P is either conducted with a long PR interval or that's a junctional escape beat.
Correct.
And the next didn't conduct. And I think more likely that the third P conducted with a very long PR, and then the next one did not conduct. And that created this pattern. It's basically the contraction of the ventricle stretches the atrium and makes the next P wave come earlier.
Professor, may I just make a comment, sir?
Yes.
Sure, Ashok.
Sir, if we see the third QRS in the rhythm strip, lead 2,
Yes.
third QRS complex, just before QRS complex, there is small, that's it, that is the P wave.
Yes.
So definitively, this is the complete heart block. This is not Wenckebach, sir.
Well, no, I'll tell you why. So, yes, it's a possibility it's a complete heart block. But if you look at
there is another P, if we go second from the last, yes, there is another P. So P merged with the QRS complex. So there is AV dissociation. There is no doubt about it.
Okay. So if there is AV dissociation, the ventricular rhythm should be a junctional escape rhythm, and it should have been regular. So the way to differentiate between AV dissociation and some degree of conduction when you see a pattern of irregularity. So in complete heart block, if you see some degree of, let's assume this is complete heart block. The irregularity can only be explained by some conducted P waves. Otherwise, you will not see the pattern of irregularity.
Sir, in that case, we can tell it, sir, high degree AV block.
I am not so sure about it. I have to sit down with the timer and caliper, but I strongly believe this is Wenckebach AV block. And look at the pattern that the first PR and then the second PR a little long and the third. And look at the 1, 2, 3, 4, 5th beat, and then the 6th beat. PR conducts, and then there is a longer PR interval. And the driver in this rhythm is the P wave. Because of this relationship, high-grade AV block, one can question about it, but it is definitely not complete heart block because of the irregularity. All right, I think we should proceed on. Thank you.
Thank you, sir.
Thank you, sir.
Rafiq bhai, when we say ventriculophasic, then aren't we implying that there is a underlying complete heart block? Because the very term is reserved for the complete heart block situation, or am I wrong?
It is not true. You can see this similar phenomena in interpolated ventricular premature beat. If you find some tracings where there is interpolated PVCs, you will find that the P to P interval, which includes the PVC, is a little shorter sometimes. So it is not necessarily true that will happen only in the case of complete heart block.
Sir, it is very interesting. So what might be the reason? Is it some reflex from the ventricle conducted to the sinus node like this?
No, so nobody knows, but the theory is that when the ventricle contracts, it stretches the atrium. And we have to understand the P to P interval. There are two phenomena. One is the rate of depolarization. Second, sinoatrial junction conduction. And also influence of the vagal tone. So, I mean, it's just a theory that the stretching causes it. The ventricular contraction pulls the atrium, and that's just a theory.
I would have read this as complete heart block with ventricular phasic variation. I would definitely call this, Rafiq bhai, some kind or a high grade AV block with ventricular phasic variation, because I cannot call it a block PSC.
All right, good. Let's go.
Now the QRS axis, the frontal QRS axis must be determined in a lying position. This is recorded in the lying position. QRS axis undergoes a rotation from right to left with aging, and right axis or left axis deviation are very rare in middle-aged persons. So here, this table shows the gradual when the age increases, the QRS axis deviates towards the left. QRS pattern, the Q3 type corresponds to QS or QR pattern in lead 3, sometimes combined with a QWave or very occasionally a QS pattern in AVF also. QS or QR pattern in lead 3 is found in normal hearts. So this is one example of Q3 pattern. There is only isolated 3 has QRS QWave, pathologic QWave, and
We cannot
T
see the
inversion.
slide, Jamil bhai. ECG slide we cannot see.
Is not seen.
Only the previous slide we can see.
Maybe due to
I can see QRS complex slide.
Yes. But next slide is different, I think, sir.
now this one.
No, it's not moving.
Slide not moving. Yes, sir.
Here it's moving. Maybe internet problem.
Also, no, not moving in my laptop.
So for the audience, while we are solving this, that look at this, we are multiple consultants. We have debate about the previous ECG, that whether it's complete heart block or Wenkeba. And it's a debate that we should have. One of the way to resolve it is to look at long rhythm strip. So we always do that. I mean, when we have confusion, we will look at the telemetry strips, we will find longer rhythm strip or do a long rhythm strip ECG to resolve this kind of questions.
Is it seen now?
Yes.
Please go to slideshow.
Sir. Is seen?
Yeah, good.
Slide show, Jamil bhai.
Yes.
So here is in lead 3 that there is QWave and T inversion, and all other leads the morphology is almost normal. QS in V1, V2 type. A QS pattern in leads V1 and or V2 found in healthy hearts in a normal variant is a normal variant due to misplacement of leads by one intercostal space high, may be associated with negative T waves mimicking enteroseptal infarction with ischemia. This is one example where there is QS pattern in V1 and V2 and T inversion in lead 1, V1. Notching versus pseudo notching. Notching is defined as a small.
Jamal, can you go back to the last slide? So one thing that Jamal mentioned, that lead misplaced. Look at the transition from V2 to V3. There is no R wave in V2, and then V3 suddenly becomes big R. Normally, you expect a gradual increase in the R wave, and that tells you that the leads were not placed probably right. Thank you.
Sir, I have a question, sir. Rubik, sir.
Yes.
Sir, how do you report this ECG, sir? Whether we will mention that this is maybe a case of the
So when we report lead misplacement, we say, let's say limb lead misplacement. We say possible limb lead misplacement, interpretation assumes no misplacement. You have to report it the way you see it, because I'm not there when the ECG was done. So if I have an old ECG which shows different, I'll say ECG finding consistent with septal MI. Please repeat ECG if needed clinically with proper lead positioning.
Thank you, sir.
Thank you.
Notching versus pseudo-notching. Notching is defined as a small, about 1 to 2 millimeter high additional deflection with inverse polarity within the Q, R, or S wave of the QRS complex. Slurring is defined as slight notching without change of polarity due to localized disturbance or delay of conduction and excitation. This happens. And pseudo-notching is merely maybe due to vectorial projections. Differentiation between notch and pseudo-notching may be difficult. Slight pseudo-notching is frequently seen in inferior limbs. So this is an example of notching. Here is one negative polarity, and in slurring there is no negative polarity, it's just an indentation. Pseudo-delta wave. Pseudo-delta wave may be present in lead.
জামিল ভাই একটু আগেরটা যাবেন। এই notching is important in the context of arrhythmia, and particularly if the patient have definitive history of MI, and they suggest of scarring.
Yeah.
Rafiq sir. Sir, would you comment?
স্যার কি শুনতে পাচ্ছেন?
Hafiz bhai, are you there?
Actually,
Adil bhai.
Assalamualaikum.
Yes, Azbek here.
I agree with that because that is, particularly the end part of the QRS complex scarring is it really determines there's a ventricular abnormality and likely there is a scarring of the tissue of the myocardium.
So I think more frequently the term is fragmented QRS
Yes.
complex or fragmented complex. Yeah.
Mhm.
True. And this ECG shows there is a abnormal repolarization. That is the problem in the repolarization of the, there is the electrical waves. That is because of the scarring, the electrical path is not the smooth. That is the
Yes.
zigzag pathway, and that is the main factor for that can initiate the re-entry. This is one of the example, the scarring presence of the nose. There is a 2 pathways that indicates, and that may be the sources of the re-entry. So this is the importance of the fragmented QRS. That is the importance of the notching in presence of the particularly when there is a chances of fibrosis like the MI or the some other.
The only problem is that this signal average EKG, we used to do a lot and there was reimbursement, but I think we know that the sensitivity and specificity for predicting significant ventricular arrhythmia by the signal average EKG is not that high, even in the post-MI patient. But there was reports that it indicates some kind of harbinger for arrhythmias, but it is not really recommended to pick up this by signal average EKG, and we stopped doing it.
Yeah, this kind of notching often found in otherwise structurally normal heart.
That is the meat of this talk, right, Jamil bhai? Because
Yes,
if there is a variant, it indicates something, and
Yes.
that actually was my question to you. But maybe I ask this question now, and for the audience, when we say normal variant, then we probably will have to accept what we mean by that. If it is a variation from normal but does not have any prognostic implication, then probably reasonable to accept that this is normal variant.
Yes.
Now, Wadud Chaudhary, should it be mentioned in the normal reporting, routine reporting, this nosing?
No, as Hafiz Bhai was mentioning, we do not actually mention it because it doesn't have that much of significance. But in a particular context, in a particular patient who have a history of syncope or something, I would rather go for Holter and other things, particularly giving attention to this fragmentation or notching.
It is often
But
reported.
most of the time, I will not pay attention to it. I will consider that there's a case of normal variation.
Many ECG reporter reports this as intraventricular conduction.
If you report this, they can say request clinical correlation or warranted. If it is a completely asymptomatic and no prior MI, nothing, then that is one meaning. But if it is a EF like 20%, several MIs and this, and then history of syncope, it means something else.
Yes.
Yes, definitely.
But that's the message actually we want to give. And when you are going to tell this is a normal variation, when you are going to say this is something maybe not that good and you have to pay more attention to it or investigate more. That will depend on particular context.
Thank you. The pseudo-delta wave may be present in leads 3, AVF, and sometimes in 2, and in leads V2 and or V3. The pattern is often misinterpreted as pre-excitation. However, the PQ interval is normal. In highly doubtful cases, tests with esmalin will distinguish it. In pseudo pre-excitation, the delta wave persists. In true pre-excitation, it should disappear. There is one example. There is some source of delta wave in lead 2 and in lead 3 also, and in lead 3 and lead V4. This simulates pseudo interval delta wave, but the PQ interval or PR interval is normal here.
Rafi, can I make a I have observed that in some of the machines, this type of delta, so-called pseudo delta is more frequent, and in some of the machines they are not present in the same patient.
Sure.
It's due to the tightness of the stylus that draw this graphs on the paper. If it is too tight, then there might be some this kind of delta wave. And if it is very loose, there will be a Q wave like thing will be inscribed in the same patient.
Rubik sir?
Yes, I mean, this is a pattern we have to recognize and we see it. You have to understand the ECG that we see today is actually a mathematical extrapolation of the original electrical signals. And some of this, but the whole point is that you look at the clinical context, and then if there is any history of SVT, what is the PR interval? So this looks a pretty typical example of.
Sir, is there any role of stress test to distinguish between the true and pseudo delta, sir?
What, Atar bhai, what are you saying?
Stress test, that is the
Treadmill test, sir.
treadmill test.
I mean, if this is the ECG of a person who has no symptom of palpitation, and I just say an ECG, I'm not going to subject that person for a stress test just to distinguish this thing. Unless there is a clinical indication for stress test, I'm not going to do it for this purpose only.
Thank you, sir.
Yes, sir. This QRS low voltage, a QRS voltage of less than 5 millimeters or 0.5 millivolt in up to 3 of 6 frontal leads is often seen. True peripheral low voltage or QRS complex smaller than 5 millimeter in 5 out of 6 or all 6 limb leads is rare finding in normal individual. This is one example of low voltage ECG where in limb leads, all limb leads shows less than 5 millimeter and in chest leads is less than 10 millimeter of the QRS complexes. and this often found in normal obese person. Then incomplete right bundle branch block, a RSR in late V1 is frequent finding in healthy people, especially in young people. This pattern may lead to a notching or RSR complex in late 3 also. So this is one example of RSR pattern in V1, and here is also a notching in the late 3. Now come with ST segment. Common pattern of ST elevation is ST elevation in V2 and or V3. In about 70% of normal ECG, the junction point or J point is 0.5 to 1.5 millimeter above the isoelectric line in lead V2 and often in V3 with consequent ST elevation. Especially in sinus bradycardia, the J point and thus the ST segment may be elevated up to 2 to 3 millimeter and rarely up to 4 millimeter due to increase in vagal tone. This common pattern of repolarization should not be misinterpreted as acute ischemia. This is one example where the J point is here and it is 2 to 3 millimeter above the isoelectric line. And
Jamil Bhai, can I interpose? One thing we should remember, whenever we measure the ST elevation, there should be 80 millisecond from the junction.
Yeah.
Not at the ST segment, just at the junction, but 80 millisecond after that.
Thank you, Adut. Now, rare pattern of ST elevation is early repolarization. Early repolarization, a marked constant elevation of J point and ST segment of 2 to 4 millimeter emerging directly from the R wave downstroke in precordial leads and or inferior leads, that is lead 3 and AVF, more in males than in females. Even the same as that of acute infarction or Prince metal angina. The correct diagnosis is based on the anamnestic and clinical findings. So this is the example in inferior leads. 2, 3 and AVF. There is elevation of the J point, the supports ST elevation, and it comes from the downstroke of R wave. And similar pattern in the pectoral leads also in V4, V5. The T waves. T waves is the most variable component of ECG. T wave is often negative in lead 3, also in lead 2 and AVF. Rarely T wave is negative in V2 and or V3, especially in young women. T wave inversion in lead V1 to V3, referred as persistent juvenile pattern, is present in 1 to 3% of apparently healthy adults. All positive and even symmetric T waves may be seen in chest leads, especially in V2 and V3, and sometimes in V4, often in young and associated with sinus bradycardia. So this is one example of juvenile pattern from lead V1 to V3. All the T waves are inverted. Best visible in pectoral leads, may be present or absent, represents repolarization of Parkinson's, and it is prominent in some electrolyte disturbances. So here it is seen in lead 2, lead AVF, also in the pectoral leads, and V4, V5, V6. QT interval, slightly shortened or QT interval are sometimes encountered in normal hearts as well. There are a substantial number of arrhythmias that occur so frequently in normal individual and may represent normal variants. 3 conditions must be normally be fulfilled to say that this arrhythmia is normal. One is absence of any heart disease, of many arrhythmias not representing normal variants, and a non-variant occur only rarely and should not be associated with very low or very high rates. First, we look at the arrhythmias not representing normal variants. These are complete AV block, second degree Mobius type 2, and high degree AV block, sinoatrial block, second degree or third degree. Ventricular phase, ventricular pause more than 2 seconds. Monomorphic ventricular tachycardia, polymorphic ventricular tachycardia like torsades and other forms. Ventricular triplets, 3 consecutive ventricular premature beats, multiple ventricular couplets, most forms of atrial tachyarrhythmias, supraventricular premature beats in salvos, there is more than 3 beats, and in high rates, more than 160 beats per minute, and ventricular fibrillation, of course. The frequent normal variant arrhythmias includes sinus bradycardia, minimal rate 45 per minute, maybe 35 beats per minute during sleep. Sinus tachycardia, maximal rate about 110 beats per minute. Sinus arrhythmia, as we discussed, respiratory one is normal variant. Isolated ventricular phase, ventricular pauses less than 2 seconds during sleep. Isolated AV junction, junctional escape beats, short episodes of AV nodal rhythm, short episodes less than 10 beats of AV dissociation, short episodes of accelerated idionodal rhythm, episodes of ectopic atrial rhythm, supraventricular premature beats, and ventricular premature beats. Now, day-to-day circadian variations occurs in QRS amplitudes and axis and in T waves at the different days and different times of the same day. Disappearance and reappearance of small Q waves. Q wave changes were fairly common. Inversion may be recorded in particular time of a day. Thank you all for patient hearing.
Excellent.
Emil, can you go back to your ST elevation slide, please?
Early repolarization.
There's another slide you had.
Yeah. This
The
one.
next one.
Was there another one
This one,
before that?
No, sir. This one and that one. This for ST elevation. Two images.
Yes. Okay, this one. So this is a very problem. Go back, please.
BERZ, sir.
Can you go back, please?
জামিল ভাই ওই দুইটা স্লাইড দুইটা ছবি সহ
BERZ, benign early repolarization.
না এরপরে
This one.
না না আরো আগে।
এইটা
Yes,
this one.
এটা
Yes.
early
I mean,
repolarization.
ST elevation is always a problem because ST elevation can also mean acute MI. It's so important to distinguish. This is interesting ECG. There are few pointers. One is if you look at V4, V5, and 5, there is a notch just after the QRS complex that supports early repolarization. And then we can also do one more thing. We can look at the amplitude of the T wave and ST elevation amplitude. If it is less than 25%, it supports early repolarization. And now, of course, we are talking about patients who have no symptom. Problem will
স্যার
be,
বুঝতে পারলাম না স্যার 25% of the
so
corresponding
if-
আসবে
so let's say T wave here is 5, 6, 7, 8 millimeter, and ST segment is 2 millimeter. So it's less than 25% of the T wave, and that supports early repolarization. I am saying it supports. So remember, if this patient is having chest pain, then you are in big trouble, because it doesn't matter how big scholar we are. we will still have to consider ischemia in those people. But these are the patterns. So the notch, presence of notch, concave ST elevation, and the ratio of ST elevation to a T wave less than 25%. Thank you.
Bhai,
Yes.
I remember when I was young, we were taught that early repolarization is benign, but now there is more awareness that early repol can be associated with arrhythmias. And they are even mentioning about different forms of early repolarization. But let me say one other thing with the early repolarization, that when, if you see this EKG or the next EKG, when the R wave and the QRS that fuses, you know, that Jamil Bhai, if you show the next EKG, that the when in the 12 lead, the way we print the EKG is now that the R of the V5 is fusing with the QRS, the S wave of the see that the V2 S wave and V3 R wave is fusing, that the fusion of this. And in our place now, they interestingly they call it Asan sign, because because these patients with LVH voltage criteria, the ST elevation is usually benign. Because this form of pattern is benign. The LVH, this fusion thing, in the presence of LVH, interpretation of ST elevation has to be that there is more in the repolarization segment of abnormality. Otherwise, it is usually benign. And then I would request that we appreciate the early repolarization now as an entity to call it normal variant. We need to be careful about the patient's context. And there are different types of early repolarization pattern: type 1, type 2, type 3, type 4. Type 4, of course, is overlapped with Brugada, but some of the athletes with the lateral leads early repolarization, probably benign. But early repolarization in a female probably bears more significance than male, particularly if the female is symptomatic with palpitation, dizziness, or syncope.
One thing is important: if you have this type of ECG, always look for previous ECG. If it's a new one, then if the patient have chest pain, then we have to consider more in the line of ACS, acute coronary syndrome.
Yes.
I was afraid to make any further comment because Rafiq Bhai is here. He may be thinking I have joined a
I read 2 test reports of athletes who had this type of early repolarization, and they developed malignant arrhythmia and ultimately died.
Yeah.
Yes. Particularly if it is inferior or combined inferolateral.
Yeah. It's like RBBP. Previously, we used to call them all RBBs are normal. Now we are saying incomplete RBBP is benign, but complete RBBP is not. It's like that.
So, sir, inferior and lateral early repolarization is sometimes carries a risk of arrhythmia.
Risk of arrhythmia, yes. Ventricular arrhythmias.
Again, detailed history is important.
Yes.
রফিক স্যার কিছু বলবেন স্যার আর কিছু
Thank you.
এটা আজকে আমি
Thank you. Very nice.
Stop sharing.
স্যার আমার একটা কোশ্চেন আছে স্যার রিগার্ডিং দ্য ডেল্টা ওয়েভ
Yes.
রোল অফ এক্সারসাইজ টেস্ট এনি প্রগনোস্টিক বা যেমন কালকে একটা পেশেন্টের পরশু একটা পেশেন্টের ডব্লিউপিডব্লিউ আমি যে হোক ইটিটি করে দেখা গেল এট দ্য হায়ার হার্ট রেট delta wave DG appears again, reappears in the recovery phase. Is there any significance of treadmill test in case of delta waves?
Sure. I mean, this is it used to be called poor man's EP study. Basically, if somebody is having SVT palpitation, these are all mute points. It has to be taken care of. If somebody presents to me with totally asymptomatic, never had palpitation, never had syncope, and I find WPW syndrome, I may put them on a treadmill. And if the delta disappears, then I can say, well, you'll do fine even if you develop AFib. But also you have to be careful about it, because when there is high adrenergic surge in the place of, at the time of AFib, they can still conduct fast. But it's just, yeah, I mean, it can be used. We still do use it from time to time.
And another point I'd like to make, and just compliment Rafiq sir, so we try to determine how many percentage of pre-excitation going on, I think through the antegrade way or through the natural way, through the AV node. If the patient exercises and their pre-excitation disappears, that means these patients are lesser risk, because when they exercise or do something, when the heart rate goes higher, more conduction through the AV node. So it's probably safer on those patients not to proceed with further testing. So that's a niche there to do this test. A certain concern when the patient has been having some symptoms, but you want to make sure the patient needs more further study, or as Rafiq sir said, is a poor man's stress test or EP study, sorry. So that's only a benefit you're getting, that if they conduct more through the AV node, the patient may be more safer condition.
জামিল ভাই আপনার স্লাইড দেখতে শেয়ার করতে পারেন আমার সাথে পরে এক সময়? This is a good collection. Thank you so much.
It's actually very good, very good.
So I have one case. So before I start this one, you see, I always tell people that if you can diagnose normal ECG, you have taken care of 90% of your patients. And that includes these normal variants. Not telling the patient that you have a disease is so important. So this is a case, I'm going to present one case that I saw just 2 days ago. So I got a call from the ER whether they need to cardiovert this patient or not. So he's a 76-year-old male, comes to the ER on the 19th of October with shortness of breath for last 7 days with minimal activity, denied chest pain, palpitation, dizziness, syncope, ankylosing claudication. He has non-ischemic cardiomyopathy in February of 2015. And by May, ejection fraction improved. In February of 2015, he had AFib with RVR and he was cardioverted, hypertension, and then chronic kidney disease. And he was chronically on carvedilol 6.25 BID. He was not on ACE inhibitor because he has chronic kidney disease. And so ejection fraction, I mentioned, in 2015, you can see in the echo, was 20 to 25%. By May of 18th, EF improved, and in echo in December of 2021 showed ejection fraction 55 to 60%. He had a cardiac catheterization, which showed normal coronary arteries in 2015. So, and this is the ECG that I was called with. As you can see, the heart rate is 124. So I need a poll. So I gave only 2 choices. Is it a supraventricular rhythm, which includes sinus tachycardia, atrial flutter, SVT with left bundle branch block, or is it ventricular tachycardia? So let's see what happens.
রফিক ভাই আপনি বললেন যে এই কার্ডিও ভার্সন করবে কি করবে না জিজ্ঞাসা করতেছি ইয়ার না?
Yes.
তো আমি একটা জিনিস বলি যে অনেক সময় আছে যে ভালো যে যদি ডিসাইড করতে না পারো at least প্রেয়ার করো যে প্লিজ পাস আউট, দেন ইট ইজ ইজি।
But okay, so this is good. So majority thought is SVT with underlying left bundle branch block, and some thought ventricular tachycardia. And these are, I mean, I will not blame any side for this. I mean, the question was that but it is so important to make a clinical decision. If it is VT, even though patient's blood pressure is 130, I cannot leave this patient overnight in ventricular tachycardia because patient may crash in the middle of the night. So I had to make a decision based on this ECG. So the rate is 124, and I'm going to go to the algorithm of if white QRS, there is concordance, then it is VT, but there is no concordance. If you look at chest lead, it may look like negative concordance, but there is an R wave. So you cannot have that pattern to call it concordance. So this is not concordance ECG. So it's negative. So based on concordance criteria, this is not VT. Next will be from onset of the R wave to the deepest point of SOIB, any precordial, if it is more than 100 milliseconds, it is VT. So I looked at it and I
It's
took
shorter.
V4, V5 and V6. If you look at V5 here, V5, from beginning of QRS to the deepest point of SOIB, it is 1 3/4. It's barely 70 milliseconds. And even in V6, it is 80 milliseconds. So it is not over 100 milliseconds. So by that criteria, it did not sound like VT. So is there AV dissociation? Unfortunately, when you have ECG like this, it is very difficult to see AV dissociation because I could not see anything. Rather, I can see that maybe if I call this a P wave, there is a P before QRS, maybe. But I could not clear-cut see any P wave or AV dissociation. So that went out of the window. So then, is there morphology criteria of VT? And the morphology criteria is, it is a left bundle type, initial R wave in V1, more than 30 milliseconds, or a notch, or this pattern. It did not fulfill that criteria because if you look, let me see if I have the ECG again. This is the ECG. Unfortunately, the ECG has QS pattern in V1, V2, but if you look at V6, even the V6, the initial R is not wide. So based on that, I felt that this was a supraventricular rhythm. So I told them, look, and we got an echo by that time. Ejection fraction now is 15 to 20%. So overnight, we decided that my feeling was that this is—
So the EF dropped now, Rafiq bhai? EF has now dropped?
15 to 20%.
So improved, then dropped.
It stayed up from 2015 until December of 2021.
Yeah.
It
So
was
what
normal.
about this lead to 1, 2, 3, 4, 5, 6, 7, 8? What is happening there?
In the beats?
Yes.
Yeah.
Yeah, there are two premature, there are two white
Yes.
12 beats, and I think those are ventricular beats.
There is some positive.
And Rafiq
Yeah.
sir, I have one question. Was the patient in left bundle branch block
These are
before? Is or
correct
new
to
or
fix
something?
it.
Well, okay.
We
So
don't
that's
know.
the part. I don't have that ECG, and I had to
Okay.
make a decision. So I made a clinical decision that this is not VT.
Hmm.
And I told them, look, it is probably flatter. Put the patient on amiodarone, see if it converts. So we started the patient on IV amiodarone, and I looked up the old ECG. This is from 2020.
Mhm.
Normal QRS, there is RSR pattern in lead V1, nothing remarkable except PSE. But I found another ECG in 2014, exactly like the VT. You see, there is QS pattern and there is a small R. It looked like left bundle. So
more likely as VT.
as supraventricular. Yes.
Supraventricular.
Yes. But look at this. If I did not have this ECG, and if the patient is hemodynamically unstable, then we have to do something more than putting amiodarone. So now I have this ECG same day at 6 p.m., 6:45 p.m. And I have this heart rate is 123. And I have this ECG again. Question is, we have resolved the issue of VT, but I'm still putting it as a choice. I have my 4 choices. What do you think it is? Can I have the poll, please?
Rate is 150. Around
123.
123.
clinically Rafiq bhai heart failure আছে?
Oh, yes, patient bilateral
Now
critical,
15%.
Yeah.
1/3 of the way of the heart,
Yeah.
hemodynamically stable. And
Or heart failure.
Heart failure, yeah, no question.
Yeah.
But this patient never had palpitation, even when the heart rate was 123. So majority say sinus tachycardia with left bundle branch block. I'm glad that they did. Still, some people said VT. 2% said atrial flutter, and then a sinus tachycardia with hyperkalemia. Sinus tachycardia with hyperkalemia, I gave it an option, but please remember, with hyperkalemia, you will not get any sharp signal. Look at V5 and V4, there's a sharp R wave initial. It is unlikely that you will see that in hyperkalemia. If you look at lead 1, it may look sinusoidal, but such a sharp signal in V4, V5, V6, it is unlikely to be hyperkalemia. Question is whether it's sinus tachycardia or atrial flutter with 2-to-1 conduction. So at 3 p.m., the heart rate was 125, at 6:45, 123. And then I'm going to go to the next ECG. This is the ECG next day. Heart rate is 122. And again, there is a small P wave here. If you look at, and I appreciate who people who call sinus tach, because it looks biphasic. But what struck me, so the nurses and my nurse practitioner said, Rafiq, this is sinus tachycardia. I said, look, something doesn't make sense to me that somebody will stay at a heart rate of 122, 23 for last 24 hours, and it is sinus tachycardia. That doesn't make any sense. And this was about before cardioversion. And so what I did, I pulled up telemetry strips. And when you looked at the telemetry strips, I found 2 strips here, and I have to use a little bit of imagination. Look at here. The hour interval increases here, and there is 2 waves. And you can say, well, this is artifact. It's my imagination, but this is at a different time, same thing.
And it is a naked eye, Rafiq bhai, but it matches, the interval matches.
Yes.
Yes.
So it gave me a little bit more confidence. No, maybe I am right. And so what we did, this is the ECG next morning. Now heart rate is 79. But if you look at, there is negative, the P wave is negative. And I still thought it was flutter with 2-to-1 conduction. And then we cardioverted the patient. This is post-cardioversion ECG. And I didn't give another ECG, which had, when the heart rate goes to 70, patient develops left bundle. So with slow heart rate, it goes to, so this is an interesting case for me, because I think we had to make a crucial decision, leave this patient overnight with this heart rate, and make the decision not to do any emergent cardioversion. And the question is now that, as I said, echo, ejection fraction now 15 to 20%. I want a poll. What do you want to do? Continue medical management, reevaluate LV function in 3 months, or medical management, implant a defibrillator prior to discharge from hospital? Poll, please.
I think we should have another option.
Well,
what about
yes,
CRTD?
I wanted to put another option, but I did not. And I know what the option is.
Okay.
We'll discuss that. Can we have the poll, please?
And please participate in the poll, please. There is no, because we want to make sure that we have like 48 participants. If I take the faculty out of this, so at least 30 should be participating, please.
So this is a good split. So I will, there is no D choice, so, but 5 said medical management, reevaluate ejection fraction 3 months, and then 6 said implant a defibrillator. Before I say anything, anybody, any of the faculty, any comment?
So when I interpret anything, Rafiq bhai, I also, for some reason, I keep this in mind, the cost. and where is the data? Where is the data and where is the cost? Because to continue, this patient has shown nicely that the LV can get better and then LV deteriorates. So we need to figure out what is the cause of this underlying non-ischemic cardiomyopathy. Is tachycardia mediated cardiomyopathy is a possibility? And then what, in that context, what we can do to minimize the cost? Because I'm reluctant to go with a defibrillator at this point, device. Before that, I need to try everything else in terms of, and we have nicely shown that there is no sudden cardiac death in this patient. We are not talking about secondary prevention. We are talking about primary prevention, and we have time to sort out that and maybe have a deep dive look.
And I have another comment on that, because more and more data are coming. Because tachycardia-induced cardiomyopathy is one of the things that patient might benefit if he can rhythm control. And as recently we had a lecture in DMC, I showed that one of the case. The thing is that I probably focus on most likely tachycardia-induced cardiomyopathy, whether you can do some permanent solution on this patient. Whether since it's a flutter, there's a possibility for ablation. So one thing, definitely need to cardiovert the patient to bring him back to normal rhythm. Then second question comes, whether they need to, at the same time, whether they could potentially ablate the patient. Third, what to do with the left bundle branch block, whether there is a desynchrony going on, whether they need to synchronize that with CRT device. That's the third question we have. So we have to keep in mind that we like to keep the patient in normal sinus rhythm as much as possible, because in all the AFib, A-flutter patient, this subgroup of patients, the benefit with the rhythm control, the benefit compared to other group.
Anybody else? Any other faculty, any comment?
Kamrul, can you connect Azizul Hasan Khandakar, raised hand?
Yes, sir.
I will make a comment, sir.
Yes.
Tachycardia is very unlikely to deteriorate that much in terms of ejection fraction. We should remember that. But
what was the comment?
Sir, any person with persistent sinus tachycardia is unlikely to deteriorate in LV function that much.
Absolutely, absolutely.
And whenever you see the LV function deteriorating that fast, it must be some sort of cardiac tachycardia, the malignant tachycardia. Atrial flutter is particularly important.
Okay, so let me answer this question. Hafiz actually alluded to it very nicely. Let's make an assumption that this patient actually a new onset cardiomyopathy, because in December of 2021, ejection fraction was normal. So when I get a new onset cardiomyopathy, I have to treat them medically for 3 months. And of course, I have to rule out ischemia if I need to, if I clinically feel it's important. And if after 3 months of medical treatment and management of ischemia, if there is ischemia means coronary disease, then ejection fraction less than 35%, then we put an ICD in for primary prevention of sudden cardiac death. So implanting defibrillator in this patient is a little premature. Second, this patient in 2015 presented with AFib with RVR and had no palpitation. And this time also with a heart rate of 124, he completes. It is possible, this kind of patients, what they do, they stay in a heart rate of 120, 130, 140, 150 without any symptom for months and develops cardiomyopathy. And it will improve, hopefully. So the hard question is whether I need to do an ablation on this patient or not. I am not going to do an ablation on this patient. Why? Look at this patient. This patient had AFib in 2015, and he did fine for 7 years without any antiarrhythmic medication. As a matter of fact, after cardioversion, I've stopped his amiodarone. So I'm going to send this patient out on medical management. Now, he's still in the hospital. Tomorrow, I'm going to repeat an echo. If I find that ejection fraction is more than 35%, then fantastic, because I don't want to put him on a live vest. If its ejection fraction is less than 35 tomorrow morning, I'm going to put a live weight in and discharge him home on medical management. And I'm hoping that within the next few months, his ejection fraction will get better. And then I'll just continue following it. The question is whether I am going to do a stress test or not. Probably I'll do a stress test, but I'm not doing a nuclear stress test just to make sure things are all right. That I'll do as an outpatient. Hafiz, any other comment on this? Hafiz? I think Hafiz is disconnected.
Rafiq sir, one question I have.
Yes.
We definitely need to do cardioversion in our resources that we have. If the patient is in Bangladesh, then concerned about what kind of medical antiarrhythmic or what you're going to choose. I know you're taking off the amiodarone.
Yes.
Because there's likelihood the patient might go back.
Sure. Yes. No question. Yes. But if you look at this patient, for 7 years, he did fantastic without any antiarrhythmic medicine. I am not going to put him on antiarrhythmic. What I'm going to do, I'm going to educate him how to check his pulse at home, either manually or with a blood pressure machine. And I will tell them, look, if at any time you find that your heart rate is constantly over 100 beats per minute, tell us. And if I find that within the next 2 to 3 months or within 6 months, he has recurrent atrial flutter or fibrillation, then I will consider either ablation or antiarrhythmic treatment, but not before that.
রফিক ভাই, আপনি এখনই কেন অ্যাবলেট করবেন?
খন্দকারের হাত তুলেছে, তাকে ঢুকতে দাও।
কি বলতে হাফেজ?
বলতেছি আপনি এখনই কেন অ্যাবলেট করবেন না?
এখন করব না কেন? Because this patient did extremely well for 7 years without any intervention for the arrhythmia. And if this patient stays without, first of all, we do not know what type of flutter it was. It is the atypical flutter, so we don't know the focus. Sometimes we do it if it is very typical flutter and frequent recurrence, but it is not typical flutter, it's atypical flutter, and I have to wait for recurrence if I am considering for ablation.
আচ্ছা, কে যেন হাত তুলেছিল, ডাক্তার আইজুল হাসান, তাকে একটু করতে দিবা, কথা বলতে দাও না?
স্যার অ্যালাউ করা আছে স্যার।
ডক্টর আইজুল, তুমি আনমিউট করে করো, কথা বলো। ডক্টর আইজুল হাসান, হাত হ্যান্ড রেজ করা।
দুই তিনটা কোশ্চেন আছে স্যার এখানে।
হ্যাঁ বলো।
না কোশ্চেন মানে কোশ্চেন করেছে কেউ বিশাল চেষ্টা করেছে, অ্যানোনিমাস একজন করেছে। ডক্টর বিশাল কোশ্চেন করছে, হোয়াট ডু ইউ ডু অ্যাবাউট দ্য অ্যান্টিকোয়াগুলেশন ইন দিস কেস স্যার?
It needs to be anticoagulated, yeah.
অ্যান্টিকোয়াগুলেশন
When the patient has
আদিত ভাই বলো।
when the patient has LV dysfunction, that's a different entity apart from we call Chats-VAS score that we consider normally for anticoagulation. If the EF is low, there's high and left atrial dimension is high, then this patient needs to be anticoagulated, because then we don't look for the Chats-VAS score nowadays, because they have high propensity of blood clot formation and stroke. So this patient needs to be anticoagulated. Definitely, depending on the choice, what kind of choice you have, the kidney function, and NOAC, if the patient is, eligible for that and the patient can afford that, then you can start on EPIC-7 or Xarelto. If Xarelto, if the patient's kidney function at least 30%, clearance is more than 30, you can safely do that. But EPIC-7 definitely can do it. Other choice is always warfarin, but difficult to manage. In that situation, yeah, patient needs to be anticoagulated with that low EF.
On the issue of anticoagulation, a couple of things I think important, because in the rheumatic mitral valve disease and atrial flutter, atrial fibrillation, they are off the chart. So we need to use anticoagulation in those patients. And also in hypertrophic cardiomyopathy and AFib and thyrotoxicosis, because these are not the patients, historically, they are not included in the SPAF, SPINAF, and all these atrial fibrillation trials. But it is true, and it still holds true. If the CHA2DS2-VASc score is high, then in otherwise non-valvular AFib, the risk also goes higher with the stroke occurrence. So in this case, CHA2DS2-VASc is already high, we know. So I would be more inclined to give anticoagulation.
So I'm sorry, I forgot to mention in my note that patient was chronically on warfarin because of high CHA2DS2-VASc score. So that's why we could cardiovert him without TE, because if he was not on anticoagulation, we had to do a TE cardioversion. We just did regular cardioversion because he was therapeutic INR for many months.
I do TE regardless, because on Coumadin particularly, I don't know how much INR control, because therapeutic INR on Coumadin, if you look at the studies, they were really not so good. So I usually, to me, it's like an additional step, but I usually do TE cardioversion.
Hafiz, this is the part of American medicine that I'll tell you what, everybody talks about INR. This patient, INR, of course, was therapeutic. Last 6 months, over 3, around 3. You know, when they want to sell this new drug, they talk about non-compliance with warfarin, blah, blah, blah. But nobody talks about non-compliance with NOACs. People are on Eliquis, they're not taking it. They're missing dose. That's the problem part. But
the non-compliance, the biggest problem, particularly even in the city of Las Vegas with the Coumadin, we have hardly any religious Coumadin clinic. I mean, this is practically becoming a problem because Coumadin clinic doesn't make money and nobody does it. So now we are switching more and more to DOAC because of that.
Yes. So, I mean, but as Hafiz pointed out, that if there is any doubt about the compliance, about INR, we always do TE cardioversion because it makes it safer for the patient. More so in patients who have history of stroke and other comorbidity conditions, TE cardioversion is really a good option. Thank you.
Excellent case, Rufik bhai.
Thank you.
Sir, my observation that in our country, patient with LV aneurysm, post-MI, or DCM and dilated heart, not many people are getting anticoagulation. They are putting 2 antiplatelet, not doing angio. Most of the time you will find that coronaries are normal, but not putting any anticoagulation.
Yeah.
Well, that is a problem. I mean, data is very clear for stroke prevention in this group, high-risk group for AFib. Those drugs doesn't really do much.
I'm too curious. Apni heart failure medicine shop ekshate throw korchen ekhane, like Entresto and Carvedilol and Aldactone,
No.
inhibitors.
This is the problem, Hafiz. This patient was chronically on Carvedilol 6.25 BID. He has chronic kidney disease.
And
So
has
he was not on ACE inhibitor and Entresto because of that. So, but talking about chronic kidney disease for the audience, the presence of chronic kidney does not say that you cannot start ACE inhibitor. You have to look at the GFR, you have to look at the creatinine level, and you start the medicine and then reevaluate kidney function to see if it gets any worse. So I'm going
to also find a new nephrologist if you can, he will be willing to give it, because they don't, sometimes it could be chicken or the egg. It could be prerenal cause of heart failure giving the creatinine high. And that exactly you need to do. And also, if there is no significant proteinuria, no cast, no glomerular disease, usually they tolerate very well and they actually benefit. And similarly, in a diabetic patients, when there is no intrinsic renal disease, SGLT inhibitors and these may actually be protective for the kidney and delaying dialysis. So yes, we are denying this very patient that we should be giving.
Sure, no question.
first thing, the patient has been on amlodipine, that should be discontinued.
Hafiz, thank you. আমি একটু মাঝে মধ্যে follow- আজিজ স্যার
হ্যাঁ পেশেন্ট আমার যতদূর মনে পড়ছে যে পেশেন্ট অ্যামলোডিপিনে ছিল আর কি, হ্যাঁ, carvedilol and অ্যামলোডিপিন. So if question right now, definitely need to have a vasodilator. Amlodipine should be discontinued. You have any question about creatinine? You don't want to give anything, put in at least hydralazine and isosorbide long acting. But in my understanding that sometimes we can start, actually can safely start the ACE inhibitor and monitor that, as Dr. Hassan mentioned. And if the creatinine doesn't rise more than 15-20%, you should continue that, even with the chronic renal disease. They ultimately would benefit.
Yes.
All right, thank you.
স্যার আমি একটু অ্যাড করতে চাই স্যার।
Definitely, please.
এটা হচ্ছে স্যার যে যদি পেশেন্টের ক্রনিক ডিজিজ থাকে স্টেজ 3 পর্যন্ত এস ইনহিবিটর বা অ্যান্টাস্টোর দেওয়ার কোনো কন্ট্রাইন্ডিকেশন নেই, উই ক্যান পুট ইট ইজিলি। বাট আমাদেরকে যেটা ফলো আপ করতে হবে যে ক্রিয়েটিনিন লেভেলটা বাড়ছে কিনা। 50% যদি বাড়ে স্টপ করব, যদি 30% বাড়ে আমরা এটাকে হাফ ডোজে কন্টিনিউ করার চেষ্টা করব। সেটা জাস্ট শুধু একটু ক্রিটিক্যাল ফলো আপ করলে হবে, এটাই হচ্ছে রিকমেন্ডেশন ক্রনিক কিডনি ডিজিজ ফ্রম দ্য পারসপেক্টিভ।
ইন্টারেস্ট বাংলাদেশে কি নামে এবং দাম কত?
অ্যান্টেস্টর পাওয়া যায় বাংলাদেশে 4টা কোম্পানি আছে।
বাংলাদেশে এন্ট্রাস্টো নামে পাওয়া যায়।
ইন্টারেস্ট নামে পাওয়া যায়।
হাফিজ ভাই,
আর হাফিজ
Entesto
স্যার, আমি আপনার
বাংলাদেশে
সাথে একমত এই ব্যাপারে। আমিও কিছু পেশেন্টের AGLT2 এবং এন্টেস্টো শুরু করে দেখছি একজন নেফ্রোলজিস্ট হয়তো বন্ধ করে দিচ্ছে, তখন আমি ইউজুয়ালি পেশেন্টকে আরেকজনের কাছে পাঠাই। দেখি আমি যতবারই দেই না কেন, নেফ্রোলজিস্ট যখন বলে এটা খাওয়া যাবে না, রোগী ওটা বন্ধ করে দেয়।
Exactly. So you need to find a new nephrologist.
বাংলাদেশে এন্টেস্টোর অরিজিনাল এন্টেস্টোর দাম কম। বাংলাদেশে হলো $22, আমেরিকায় তো হলো 200 মিলিগ্রাম, আর আমেরিকায় বোধহয় $11, তাই না?
Right.
বাংলাদেশে এটা অনেক কম।
আমাদের দেশে কিন্তু
অরিজিনাল
অনেক কম,
এন্টেস্টোর
অনেক কম, অনেক কম।
ওরা এটা স্পেশালি
আর
বাংলাদেশের জন্য
যদি দেশি কোম্পানি হয় তাতে আরো কম, যদি ইন্টারেস্ট হয় তো একটু বেশি, কিন্তু দেশি কোম্পানি হলে তো একদম কম।
So
আর অশোক দা, আপনাকে যেটা করতে হবে, এটা ফ্রিকুয়েন্টলি আমরা পাচ্ছি আর কি, যে নেফ্রোলজিস্টরা অলওয়েজ এটা করছে আর কি। তো ওদের সাথে একটু ভালো রিলেশন তৈরি করেন, ওদেরকে একটু আপনার যে গাইডলাইন গুলো একটু মাঝে মাঝে হোয়াটসঅ্যাপে পাঠান, তাইলে দেখবেন যে একটু কাজ হয়।
একটা মিটিং করলে হয় যে কার্ডিও রেনাল এবং হার্ট ফেইলিওর, কিডনি ডিজিজ, একটা ওদেরকে আমাদের এক পেজে নিয়ে আসতে হবে। কারণ অনেস্টলি আফটার হার্ট আই লাভ the organ most is kidney.
So this is the problem. This problem not only in Bangladesh exists in America. That
Absolutely.
two issues. You cannot start carvedilol because blood pressure is low. That's one fallacy. You cannot start ACE inhibitor because creatinine is high. Both are wrong notions. We can always try these medicines and then follow. The other problem is when one doctor says, look, you should never be on this medicine, it's going to kill you. It is very, very difficult to start that medicine. But we can always sit down with the patient that, look, I'm going to put you on the medicine. I'm going to check your kidney function because your kidney function may be secondary to heart problem, that your kidney function is abnormal. And once we can improve it, kidney function will improve. And that is where the dilemma is. And of course, as Hafiz mentioned, that it's continuing education. I mean, we grew up at a generation when if I put beta blocker in heart failure patient, I would never pass MBBS. And look at where we are today, that we are giving beta blocker to patients with low ejection fraction. My professor would have killed me if I gave beta blocker to a heart failure patient. Thank you. I think we can close today.
Yes, sir. Thank you very much, sir. Actually, very excellent presentation. Abdullah Jamil, congratulations. Thank you very much for your nice collection and beautiful presentation. Finally, excellent case by Rufik sir. Sir, our next session on the 6th November on pediatric ECG. Naharuma Haidar. Naharuma, you are here? Dr. Naharuma?
जी sir. Assalamu alaikum sir. Achi sir.
So Naharuma, we are waiting for your talks. That is on the 6th November.
So 6th November তো ফার্স্ট সানডে হয় মনে হয় স্যার মাসে, ওটাতে হবে স্যার?
That is, I will let you know the dates exactly.
আচ্ছা স্যার 6 নভেম্বর হলে আমি পারবো স্যার।
Our next session by the Dr. Rahiduzzaman, sir, pediatric ECG, sir.
Okay, sure. See you then. Goodbye.
ইনশাআল্লাহ স্যার।
So Abdul Wadud Chaudhary, I'm requesting you to wrap up the session, today's session.
Today's session is important in the context that, as Rafiq sir was saying, if you know what is normal, then you can actually identify abnormal quite much better. That's the point. You do not put the patient through unnecessary anxiety or investigation or medication if you know that it's a normal variation. Jamil bhai, I would have been happy if you have put that the small Q in inferior leads that disappear with deep inspiration. Repeat the ECG with deep inspiration, the Q will get well. I sometimes tell the patient, আপনাকে আমি এক্ষুনি ভালো করে দিচ্ছি, আপনার এটা দেখেন যে হার্ট অ্যাটাক যেটা বলছিল এটা চলে যাবে, বলে ওকে ওটা করে দেখাই যে এই দেখেন এটা চলে গেছে, ইটস নর্মাল। So that thing should be put in there as a normal variation. That will be much better. And today we really enjoyed the whole thing. Thank you, Jamil bhai. Thank you for an excellent collection of normal variations.
Any comments?
Omanta, would you make some comment, please?
No, thank you. I enjoy a lot of things from Jamil bhai lectures, and also Hafiz bhai and Rafiq sir and Wadud, and also Athar Ali sir's comment. ECG is the basic thing of cardiology. You mind it. When I take a lecture, I told the student the ECG is the cornerstone of the all tidbits should be known. So I think it's a very good arrangement by Wadud and Athar Ali sir. Thank you. Good night to all.
আমি একটা কমেন্ট করতে চাই, সেটা হচ্ছে কি যে এই ইসিজি বেসিক্স এন্ড বিয়ন্ড এইটাতে ওয়াদুদ, আতার ভাই এবং রফিক ভাই আমাকে ইনক্লুড করছে, এবং আমি দেখলাম যে এইটা ইনক্লুড হওয়ার পরে আমি এই ইসিজি এখন দিয়ে শুরু করি রেসিডেন্টদেরকে। আমার মানে টিচিং এ আমার পপুলারিটি এখন স্কাই রকেট এই ইসিজি দিয়ে শুরু করা হয়েছে। সো দিস ইজ এ থ্যাংক ইউ অল।
Actually, it's এত important, এত interesting. It can tell you a story.
Arun Maski.
Arun is here.